I'm sure you're happy to be out of ICBSE or whatever it was you were involved in recent weeks.
I'd like to say impeccable timing, because poor old John Hines has now got the problem of sticking everything online, which is really very difficult.
John, yes, yes. And greetings to Sophie. We haven't met, but it's nice to see you. And Douglas, are you there?
I'm here.
Douglas,
yes.
good to see you.
Good evening. Hi.
We've just before everybody joins, we've been running these. Really, they started out as an emergency response to COVID, and now it's really taken on its own identity as a weekly webinar, and we are now covering very different topics each week, everything from pediatric emergencies to head and neck surgery, and now vascular surgery. And so it's been an interesting development. And the extraordinary thing is the range and the extent to which we can get people joining us in. I got somebody took a selfie from India watching me online and sent it to me. So it's extraordinary. Anyway, it's just past a minute past. No, it's exactly 6 o'clock. We usually wait for a minute or two to get everybody settled in. I saw the letter that was going out from the chief medical officers and the academy in the UK out today to all medical practitioners. It makes pretty grim reading. You're all in, certainly in the UK, you're in a lot tougher situation, I think, than we are here, even though we're having it quite. Okay, Bridget, do you think we should start?
Okay.
Okay, well, welcome to the Wednesday evening webinar. We have nearly 100 signed in to watch it directly this evening. And then I think there are about 150 who are going to watch the recorded version of it. So you're all very welcome. This evening is going to be on vascular surgery, and we're delighted to welcome Frank Smith, Sophie Renton, and Douglas Orr from the UK, vascular surgeons all. And I'm going to ask Bridget Egan, council member and vascular surgeon who's well known to you all. Bridget, would you like to do the introductions and to lead off?
Okay, thank you very much. Good evening, everybody, and thank you for joining us. Thanks, Mr. President, for giving Vascular the opportunity, and I hopefully the talks tonight will be of interest to people. I think they are interesting topics, and I thank all those who have agreed to talk. So to kick off, I'd like to introduce Professor Frank Smith, who is Professor of Vascular Surgery and Surgical Education at Bristol University, and he's an Honorary Fellow of RCSI. He has held a long interest in thoracic outlet syndrome since he visited David Roos 25 years ago. Currently, he is concerned with safety in surgery, education and training. He is collaborating in setting up the first dedicated thoracic outlet syndrome surgical unit in the UK, aiming to improve reporting standards and setting up a registry. He's also involved in introducing changes to the training curriculum of vascular surgeons to include thoracic outlet syndrome. He's a co-author of the second edition of the multi-author textbook on thoracic outlet syndrome. So, Professor Smith, thank you very much for your time this evening, and we look forward to your talk.
Well, thank you very much, Bridget, and also thanks to Ronan O'Connell and the other fellows of the college. I'm absolutely delighted. In fact, I haven't got an honorary fellowship. I've joined ad eundum, and I'm delighted to have joined the college with a fellowship, because I've actually spent quite a lot of time there in the last few years, both at meetings and so thank you for having me. I'm going to talk a little bit about thoracic outlet syndrome tonight. I've got quite a few slides, so I'm going to make it a romp through the topic. It's a niche topic, really, within vascular surgery. I wouldn't claim to be an expert by any means, but I've got an interest in it. And it's something that the Vascular Society Great Britain and Ireland is looking at in terms of development, and we're trying to raise awareness of the condition, but also standards of reporting and collecting data, and to develop a more uniform approach in terms of how we deal with the subject. So I think Pauline Lyons is doing the slides for me. If I could have the next slide, please, Pauline. What I'm quickly going to do over the next 15 minutes or so is go through various aspects of the anatomy, how the overlapping components of thoracic outlet syndrome present. We'll have a little look at what are the topical investigations at the moment for thoracic outlet syndrome, because diagnosis is always a quandary. And then we'll look at a few aspects of management, although I don't think there's going to be time to go into great detail in terms of operative management. Next slide, please. Really, if we're going to consider this, the most important starting place is the anatomy. And we recognise now that there are several places in which the various components, the clockwork, if you like, emerges into the arm from the thoracic outlet. And the key anatomical structures are the first rib and the clavicle, which you can see on this particular diagram. The scalene muscles, the anterior scalene, which you'll remember from your grilling in fellowship, if you were like me. You were handed a bit of first rib and asked which side it had come from and what the lumps were. The anterior scalene muscle inserts onto the scalene tubercle in the first rib. And then behind that are the scalenus medius muscles. Between the two emerge the subclavian artery and the brachial plexus, and anterior to the scalenus anterior muscle is the subclavian vein draining blood from the arm. So looking at that, you can see the scalene triangle, and within that area, the brachial plexus may be compressed by the muscles or by vague bands arising from the transverse processes of the cervical vertebra, or indeed by aberrant bony structures such as a cervical rib. And beneath that is the costoclavicular space, the bit, if you like, between the clavicle and the first rib. And we'll come back to that in a minute. That's an area in which the subclavian vein can be pinched, giving rise to venous symptoms. And then gradually over the last 10 or 15 years or so, we've recognized the increased importance of the pectoralis minor space, just medial and inferior to the coracoid process of the scapula, onto which you'll remember the pectoralis minor inserts. And the tendon of that can compress the subclavian vein, the brachial plexus, and the artery as they go into the arm. Next slide, please. These were diagrams from one of David Roos's papers. David Roos was a vascular surgeon in Colorado who carried out over 2,000 rib excisions, and back in the early 1990s gave an honorary lecture to the Vascular Society in which he very elegantly explained the nature of the type of bands and the anatomical features that can compress the structures running into the arm. You see on the left side, there's a normal appearance of the thoracic outlet, and on the right side, you can see how costoclavicular compression could compress the artery, the nerves, and indeed the vein, which isn't seen on this picture, and how the pectoralis minor tendon can be involved as well. Next slide, please. And when we're operating in the neck, it's probably just as well remembering these important bits of anatomy because these are potentially prone to damage if you're going to do a supraclavicular exploration. It's something we ought to remember in consenting a patient, that we explain that there is a risk to the phrenic nerve, which runs down on the anterior border of scalenus anterior. The brachial plexus is obviously potentially at risk, but posteriorly, running with the scalenus medius muscles, it's the long thoracic nerve to serratus anterior. So if you damage that and don't recognize it at surgery, the patient could have a winged scapula. We don't really often get back as far as the cervical sympathetic chain on the neck of the first rib. But if you're doing a transaxillary approach, it is possible to damage the intercostobrachial nerve, which you can see on the right-hand diagram, and that can give the patient a nasty neuralgia on the medial upper aspect of the inner arm. And so it's always worth looking for that in a transaxillary first rib excision. Next slide, please. And then Bridget and I were talking a few weeks ago, and we were talking a little bit about the management of venous thoracic outlet syndrome, VTOS, and we see patients present with occlusion of the subclavian vein, and they're often fit athletes who are playing badminton or squash players, or we've seen it in wrestlers and people who spend a lot of time in the gym, and sometimes in professional musicians who build up their muscles around there. And you can see that the potential mechanism of occlusion of the first rib would be a costoclavicular compression with involvement of the subclavius muscle and the costoclavicular ligament, which is almost a bit like the lacuna ligament in the femoral canal, and can pinch the vein and cause that to occlude. So that picture is quite important. Next slide, please. And then finally, with respect to anatomy, there are various potential anomalous bony bits, if you like, the cervical ribs, that can have any sort of presentation, tending to arise from the transverse processes of the cervical spine and inserting either onto the second rib or potentially onto the first rib. And there can be any combination of fibrous bands replacing the ribs. Over on the right-hand side of diagram B, you can see a true cervical rib inserting onto the first rib and compressing the subclavian artery between the scalenus anterior muscle and the actual bony extra, giving rise to a stenosis and then a dilatation in the post-stenotic bit of the artery. Next slide, please. So a lot has been published about thoracic outlet syndrome, but I've only included 3 publications here because these really summarize the state of where we are at the moment. The first was a Cochrane review undertaken in 2014, which, despite the evident Scandinavian ship of the authors, was produced and published in the United Kingdom. And that really drew to the conclusions that almost all the data with respect to thoracic outlet syndrome is limited to poor quality studies. There's very limited follow-up. There's deficient evidence, lack of accepted diagnostic criteria, and a free-for-all with respect to potential interventions. Next slide, please. So if you are going to consider doing thoracic outlet surgery, or you really want the current state of where we are at the moment, probably this is the paper to pick up. It's easy to access on the internet. It's the reporting standards of the American Society for Vascular Surgery for thoracic outlet syndrome. And all the big players in the United States are on this paper. And the aims of this paper were to standardize the terminology, the nomenclature and definitions of thoracic outlet surgery, and to establish consistent reporting standards by which outcomes could be measured. So if you want to read one article on thoracic outlet to give you a bit of an idea of what the playing field is like, that is probably the one to read. Next slide, please. And if you're going to practice thoracic outlet surgery, then I'd probably just recommend this book by the same authors. It's a sort of distillate of all the good evidence that we've got so far for surgery in thoracic outlet syndrome. And I must admit, I read it regularly when I'm reviewing cases and about to operate on them. And they're just about to produce a new edition, I think, which is coming out in October. So if you're a consultant surgeon and you're doing this, then that's probably worth having on your bookshelf to refer to from time to time. Next slide, please. So thoracic outlet syndrome, we've talked about the different structures, and I'm not going to labour the point in detail, but it really consists of a range of different conditions. You can have conditions affecting the nerves, neurogenic thoracic outlet syndrome, which can cause paresthesia, pain, muscle wasting, and the neurogenic type limitations that you might expect. The arterial system can be affected if the subclavian artery is pinched and you get arterial symptoms, and the venous pinching of the subclavian vein can result in either venous occlusion, which has the eponym Paget-Schroeder, or McCleary syndrome, in which the vein is partially and transiently pinched, giving rise to intermittent obstruction of the veins in the arm. And there is, of course, overlap between all of these, because true thoracic outlet syndrome may, for instance, result in arterial and neurogenic symptoms, and rarely do you just get VTOS on its own without some neurogenic component as well. Next slide, please. And again, I'm not going to go into the history and examination in great detail, but it's profoundly important in this condition because so many other things can result in the sort of symptoms that arise. But as you might expect in the arterial variant, you may get claudication and rest pain of the upper limb. There can be numbness. You look for things like pallor and coolness in the limb. Digital ulceration and peripheral embolization are gross signs, and you might see those on a relatively acute basis. When you're examining the patient, you'd examine for a bruit and a pulsatile mass, for instance, for a poststenotic dilatation in the supraclavicular and infraclavicular regions, and blood pressure measurements important. In VTOS, as you might expect, there's evidence of venous obstruction with swelling of the limb, dilated vein, cyanotic discoloration, upper limb swelling, and then there's an entire constellation of different neurogenic type pains, paresthesia and numbness that can arise depending on which bits of the brachial plexus or the peripheral nerves are pressed upon in a neurogenic TOS. Next slide, please. And the other thing about the history is that patients present with all sorts of weird signs that you would think couldn't possibly be associated with pressure in the, say, the scalene triangle, and these can be as far-fetched as mental acuity, face and ear pain, those sort of symptoms. A history of trauma, particularly whiplash injury or fracture of the clavicle or a fracture of the first rib, may be very relevant in these cases. And the effect that the symptoms have on work is really important if you're going to consider intervening. And that involves even things like whether a patient can hold a telephone up to their ear for any prolonged time, whether they can brush their hair, whether they can drive distances. And usually it's elevating the arm, lifting the arm up to do something that causes the symptoms. And I'm afraid I still stereotype and ask people whether they can hang curtains or stack shelves or paint the roof of the Sistine Chapel in terms of trying to work out what sort of effect these symptoms may have on their life. Smoking, alcohol, medications, allergies are important. And the other thing is it's one of those conditions that can be potentially prone to litigation, particularly if they think there's a work-based injury that set this all off, or they're still contesting the result of a road traffic accident or something. So you have to be very aware of that. Next slide, please. And then the tests that we use as characteristic provocation tests include the elevated arm stress test, which you may know as the Roos test, arms rotated, abducted and clenching and unclenching the hand for 3 minutes. And if a patient has significant symptoms, they won't be able to undertake that test and they will have to stop, and it's worth recording the symptoms that make them stop. Next slide, please. The upper limb tension test is important. If you hold your arm abducted, flex your hand, and then laterally flex your neck away from the abducted arm, that puts tension on the brachial plexus and may reproduce symptoms. If it only happens when the elbow is flexed, then that may be because the ulnar nerve, which of course is also the C8T1 nerve root as it passes over the first rib, is being stretched at the elbow. And that may in fact be due to a cubital tunnel syndrome as well. So next slide, please. And then Adson's test consists of loss of the pulse with the arm abducted, externally rotated, and a flexion of the head towards the arm. That may result in loss of the pulse. I personally have found that a fairly equivocal and not very useful test, and I think that's the opinion of many of the people we're discussing this with at the moment, but it is part of the battery of tests you might be expected to document in thoracic outlet. Next slide, please. And then there are the gross things that you look at in patients with severe neurogenic outlet, thoracic outlet. You may see muscle wasting here of the hypothenar eminence and the interossei, the lumbricals between the metacarpals, and indeed the thenar eminence here as well. And that may well be due to C8T1 nerve root problems. Next slide, please. Most of our medical students recognize that something is not right about this hand, and this is digital embolus from in effect a subclavian artery aneurysm distal to a stenosis. Next slide, please. What investigations do we use? Well, this is a list of the investigations, but it's probably better to have a look at some of the illustrations. Next slide, please. So straightforward X-rays are useful of the thoracic outlet. Chest X-ray, a cervical spinal X-ray may reveal the presence of a cervical rib, a true cervical rib in the right-hand illustration. And a prominent process of T7 is often a sort of vestigial remnant of a cervical rib, and you'll find fibrous bands at surgery running down to the first rib, which may be sitting immediately underneath the brachial plexus and may be part of the problem. So that it's essential to get some plain X-rays. Those can be useful. Next slide, please. It's also important to get an MRI of the spine, because so many of these patients will in fact have a problem with the spine. And here you can see a disc impingement, which may be causing the patient's symptoms. So it may be nothing to do with thoracic outlet. But if you ask for a cervical spinal MRI and ask them to image the brachial plexus as well, you may sometimes be lucky and see some form of bony or fibrous impingement on the plexus. Next slide, please. All of our patients get a duplex, a one-stop duplex. We now have a specialist thoracic outlet clinic, but they get a duplex when they arrive. And if you do that with the arm adducted and then abducted and externally rotated, you may see signs of vascular compression. In the upper two slides, you can see an increase in blood flow velocity, and in the lower two slides, in fact, when the arm is abducted, there's a complete blockage of arterial blood flow, and that may point you towards thoracic outlet. Next slide, please. Nerve conduction studies are useful. They're principally useful for excluding median nerve compression at the wrist, carpal tunnel syndrome, or ulnar nerve compression at the cubital tunnel. They're often equivocal, and then they're not much use at all. But if you're ever told positively by your neurophysiologist that there appears to be a problem at the thoracic outlet, then they can be helpful. Next slide, please. And really the most important diagnostic test that has emerged in the last 3 or 4 years has been the use of scalene and pectoralis minor ultrasound-guided local anesthetic nerve blocks. You get the patient to do their provocation tests prior to nerve block, and then under ultrasound control, you block the scalene muscles, which causes them to relax and take pressure off the structures in the thoracic outlet. And if the patient has a positive response saying that they can do their provocation tests much more easily, then that's strongly diagnostic of thoracic outlet, and that can be done for the pectoralis minor tendon as well. So that really is the new advent, and we see no reason why vascular surgeons themselves shouldn't be doing these blocks, bearing in mind they're doing all sorts of other things under ultrasound control now. Next slide, please. And then finally, if we're expecting vascular problems, here's an arm abducted with an obvious stenosis during arm abduction on an MRA scan. Next slide, please. Here's a post-stenotic aneurysm, which in the lower illustration has discharged brachial artery emboli, and that is an acute problem arising from arterial thoracic outlet. Next slide, please. And in this condition, you need to explore the artery via the supraclavicular route. Usually, you probably have to excise the aneurysm and put in a little inlay graft, either of vein or Dacron. At the same time, you need to carry out a traditional procedure of brachial embolectomy to get that clot out of there and restore circulation to the arm. And then you, of course, have to excise the troublesome first rib or the cervical rib. Next slide, please. And here is a specimen of that excised rib. I have to say, this was not my rib excision, and I've never seen a rib come out quite that cleanly. When I do it, it's invariably a little pot of nibbled bone and little separate chunks of bone, because it's kind of hard to get a big specimen out like that through a small incision. But that's what we're trying to achieve. Next slide, please. And then finally, in VTOS, here's an occluded, an occluded vein. And in these cases, if you catch them in the acute phase, it may be worth trying to thrombolyse the vein to restore function. And if you're going to do that and you restore function, at that point it might be worth doing a transaxillary resection of the rib. And if there are persistent problems, you may end up later on doing venoplasty to try and open that up again. Where you don't catch it acutely, we tend to treat them conservatively by putting the patients onto anticoagulants and leaving them on for 3 to 6 months, reassessing and seeing where the patient is. Often they can just get through it without any intervention at all because of the good collateral supply, and most of these patients will eventually settle down. Next slide, please. And that's just another X-ray of a venous compression. Next slide, please. So the management, as in all things surgical, conservative treatment is the optimal way forward if you can get away with it, getting the patient to adopt their posture, learning to live with what they know as the diagnosis if they can do. Physiotherapy may help posture. Cervical ribs, where they're the obvious cause of a problem, should be excised, probably if the patient is fit, because that's an obvious bony problem that shouldn't be there. We take away the scalene muscles as much as we can of the anterior scalene and the median scalene muscles to try and reduce the risks of subsequent compression. And then you need to tailor your operation to remove the first rib depending on what particular variant of TOS you have. And that may mean that you carry out a transaxillary rib resection to deal with the vein, because you can get to the anterior part of the rib, or if it's brachial plexus or artery, you may well do a supraclavicular approach to resect that part of the first rib underlying those structures. Nowadays, if we find that the patient has tenderness in the subcoracoid space, we would also carry out a pectoralis minor tenotomy, because we recognize that that is a cause for persistent symptoms after a first rib resection. Rarely do you have to do sympathectomy, which I'd do via a transthoracic thoracoscopic route, unless the patient has something like a reflex sympathetic dystrophy. Next slide, please. And that just shows the incision that you'd use for pectoralis minor tenotomy. Next slide, please. Assessment is important, and these are the sort of objective quality of life questionnaires that it's best to do prior to any intervention, and then you can use these to see if there's been any significant post-benefit. Next slide, please. And in terms of a service that we now offer, we recognize that really all of these people contribute to this. So we work with a spinal neurosurgeon to deal with the spinal problems that may arise out of those, an orthopedic surgeon. We have a dedicated physiotherapist. When we feel we can't do anything for the patient, they'll often be referred on to the pain team. Our radiologists have become expert at the venous manipulations, the thrombolysis, and also the injections that we need to do. The neurophysiologist provides us with the nerve conduction studies, and as ever, our vascular technologists are key in diagnosing things on duplex. Next slide, please. So I'm sorry, that has overrun a bit and brings me to the end. And what I think we should take away from this, that actually TOS it may have distinct entities, but there's significant overlap. Absolutely key are the examination and the history. More than in the past, we should consider pectoralis minor syndrome as a potential residual problem. The blocks are useful tests. If you're picking surgical approaches, pick them very carefully for what you actually want to achieve. And we recognize now through the Vascular Society that we need some sort of standardized nomenclature and reporting. There is a consensus group which anybody is welcome to join, and I'm sure Sophie and Douglas would agree that if you want to join, the more representation we can get, particularly as well from Ireland, that would be great. And the last thing, as I get older and approach retirement, I think it's so important to select your cases very carefully, and above all else, do no harm. So thank you very much for having me, and I do apologise if that's gone on a little bit longer than I meant. Thank you.
Thank you very much, Frank. That was a fantastic talk, and it was very comprehensive. I think you actually answered one of the questions that came in earlier today about, is it possible just to do thrombolysis and a venoplasty and leave the first rib? And you did refer to that in your talk. So we'll open it up now for any questions. If you want to use, we will allow free questions if you want to use the hand function, if anybody's any questions. Yes. I see a hand there, I can't just see the name with it. Would you like to answer the question?
Hi, this is Meki Milani. Thank you, Professor, for a fantastic talk. I am actually very interested in TOS, and I got some training in my fellowship for it. I have a question about the duplex that you do. Do you do it in just the 2 positions, or do you do a duplex in 4 different positions?
You go really on what the patient tells you. You're lucky there because it's a dynamic investigation, and patients get their symptoms in different positions. So you go to the position which they usually are provoked in, and you try and work out what's happening there. Not everybody has exactly the same thing, but pretty extreme abduction and external rotation will usually provoke the symptoms.
Thank you.
Thank you. Thanks, Meki. Sharif?
Thanks so much, Bridget. Frank, it's a fantastic presentation. Thank you so much. I really enjoyed it tremendously. The whole idea that we currently do whenever we get this patient now, scalenectomy, is it more than enough? I usually do extensive scalenectomy and leave everything as it is, except if the cervical rib is complete. You have the biggest experience in that, so what's your say about that? Is it supraclavicular scalenectomy, anterior scalenectomy is more than enough, or you have to go aggressively to get this lovely picture that you showed us?
If you'll forgive me, sorry, sure, you have to turn your thing off. It's terrible echo coming back. My practice has changed over the years. Last few years, I went across to the States and I visited Rob Thompson in St. Louis and Carl Illig in Tampa. And I watched what they did. And I'd worked with John Thompson quite a bit. We both went to see David Roos in the past. And he, if you remember his original lecture, you're too young to remember that, Sharif, I'm sure. But, he did all of his via a transaxillary approach. But what I've learned is that often if you just do the scalenectomy, the bones are still a residual problem. And I used to do some scalenectomies and I was forever having recurrent symptoms and patients would come back. And I was almost too scared to take out the rib because there's a lot of clockwork there. And you almost have to get into a pattern of, doing the same operations, a bit like carotids, time and time again. And I've become a bit braver now, and I've worked out how I can get a bit of rib out. And usually a completer clearance sorts the problem out. You do have a lot of people coming back if you're just going to take the muscles off. Thanks.
Thanks so much.
Bridget, you seem to be frozen.
Sorry, beg your pardon, I was on mute. Thank you very much, Frank, for that excellent talk. Just as I was saying, I think the key to the whole thing is actually the anatomy of the area and an understanding of the anatomy. So we'll move on now to our next speaker, which is Sophie Renton. And Sophie is a consultant vascular surgeon in Northwick Park in London. She is Secretary of the Vascular Society of Great Britain and Ireland. And I've asked her to talk about the new NICE guidelines on aortic aneurysm repair, which initially in their draft format were very controversial, I think is probably fair enough to say. And then they seemed to slip under the radar in March of this year. And I thanks Sophie for agreeing to give this talk this evening.
Thank you very much. Yes, it is interesting when a set of guidelines becomes so controversial. Next slide, please. What you've got to remember is that the NICE guidelines are really guidelines that are designed to inform the full range of practice, from general practice through to secondary, tertiary care. And in those draft guidelines, there was a lot that was really excellent. I mean, it covers diagnosis, it covers emergency transfer, it covers the monitoring and the reducing risk of rupture, predicting surgical outcomes, but it also dictated how we should be managing both unruptured and ruptured aneurysms. Next slide, please. As I said, there's plenty that was really good in the original draft guidelines. So in particular, identifying people who are at risk, Good guidelines with regard to the timing of referral, both for the non-screen detected, because obviously this is running in parallel with the screen detected, where there was already clear guidelines for referral. And in particular, increasing the awareness of potential for rupture of an aneurysm as a reason to present to A&E. Next slide, please. So in terms of reducing risk, very sensible things like stopping smoking, managing hypertension, all guidelines for general practice, and guidelines for the frequency of surveillance. Next slide, please. Now, where the controversy arose was that what the draft guidelines did was to actually dictate how we should be treating aortic aneurysms. So they supported what had been practice with considering a repair if a patient was either symptomatic or had an aortic aneurysm over 5 centimeters, or it was growing 1 centimeter per annum. They then went on to say that we should be offering open surgical repair unless there were anaesthetic or medical contraindications. But if a patient had anaesthetic or medical contraindications, they said do not offer EVAR repair, either for straightforward infrarenal aneurysms or for complex EVARs. Next slide, please. So, and then when they went on to advise with regards to ruptured aneurysms, they said that we should be considering EVAR repair or surgical repair for people with ruptured aneurysms, but pointing out that EVAR provided more benefit than open surgical repair for elderly patients, for those over 70, and especially for women, whereas an open repair would be better for those under 70. It also proposed that you should only consider open surgical repair for people with a ruptured complex aortic aneurysm. Next slide, please. So why did NICE come up with these recommendations? So their argument was that there was no evidence that EVAR for people with an unruptured infrarenal aneurysm got long-term benefit in comparison to surgical repair. And so whereas EVAR may have reduced numbers of perioperative deaths, it has more long-term complications, and these complications mean that people will need further procedures. And that there is evidence that EVAR is associated with worse long-term survival than open surgery and has higher net costs than open surgery. So the evidence shows that even if the long-term benefits were achievable, they could not plausibly be sufficient to outweigh costs. And NICE has always had cost at its heart. So up to now, it has always been assessing drugs in particular and assessing them on the basis of whether it is cost effective to offer them as a treatment. Next slide, please. So how do they get to that decision making? Well, the problem really lies in the fact that they very much focused on the randomized controlled trials of EVAR versus open surgery. And these are the EVAR-1 trial, the ACE trial, the DREAM trials. They also looked at the cost effectiveness studies, which were all basically based on the EVAR-1 study, which, saw very well, but at 8 years, only 60 of the original 1,200 were actually being followed up. All of the trial data reflected data that was acquired between 1994 and 2004. They did not use data from registries. They did not look at studies comparing different types of EVAR. And in particular, they did not look or take into account the improvements in UK mortality data, which we had done a lot of work following a quality improvement programme to reduce our open mortality rate, so that we know that we had an open mortality rate of about nearly 8% in 2008, and that has been more than halved over the subsequent 10 years. New slide, please. So when this was put to us as the Vascular Society, we were invited to make comments, and we were just one of 200 different healthcare groups that put in objections to the proposals. Our objections were based on, well, essentially that this was completely unprecedented to take an operation that was actually established therapy and say we couldn't do it anymore. Furthermore, it's very arbitrary, this fit or no, not fit. Patients aren't binary. They have degrees of fitness. And what may be medically fit for an EVAR may not be medically fit for an open procedure. This very black and white approach gives no reference to patient choice or informed consent. And one of our biggest concerns was that if we went down the route of actually offering open surgical repair to patients who currently may be offered EVAR repair, this would greatly increase the use of our ITU beds and our length of stay. We were also concerned that this was actually out of kilter with guidelines that had been produced at about the same time by the Europeans and reflecting American practice. And as well as this, there were major concerns about training issues. If we start retraining our surgeons to do open surgery, how are they going to have the skills to do the EVAR repair when the rupture comes in? Next slide, please. So when you look at patient choice, one of the groups that was asked to comment was the Liverpool Aneurysm Public and Patient Information Group. And they looked at the guidelines, and the results of their discussions were that patients want to be informed about the treatment choices, and they need as much evidence as possible to make that decision. They do not like the idea of being offered one best treatment based on guidelines, and they didn't think that was adequate counselling for consent. Patients may take different choices under different circumstances, on the same circumstance with the same information. And they understand the importance of NHS treatment costs, but at the same time, they don't believe that treatment costs should play a role in the selection or offer of treatments. Next slide, please. Now, 18 months passed and there was an awful lot of politicking, negotiation, standoffs. The original authors did not wish to change any of the guidelines in any sort of way, and there had to be another author had to be brought in to try and find a route through this. And so they were published in March 2020, and of course, because that was when COVID rolled out, it did mean that they rather slipped under the radar. But they are a pragmatic answer to the various concerns that were raised. So what we find now is that the NICE guidelines do say that when you are discussing a repair, you should discuss the overall balance of benefits and risks of a repair versus conservative management based on their current health and expected future health, and that the choice of treatment will depend on the aneurysm size and morphology, their overall fitness, risk of rupture, short and long-term benefit, and the uncertainties around estimates of risk. And all of these should be discussed in that decision-making process. New slide, please. They do recommend that we offer open surgical repair for people with unruptured aneurysms unless it is contraindicated. And we are allowed to consider endovascular repair for people with unruptured aneurysms who have either co-pathologies such as a hostile abdomen, or that they have anaesthetic or medical comorbidities that would contraindicate open surgical repair, which really is pretty well what we do now. New slide, please. With regards to complex aneurysms, they still do recommend open surgical repair where possible, and to only consider an EVAR repair if the risks has been complicated and the uncertainties around whether complex EVAR improves perioperative survival or long-term outcomes are discussed. They do recommend that special arrangements are made for consent, for audits and research, and of course, all cases should be monitored through the National Vascular Registry. Next slide, please. Next slide, please. So, in conclusion, the final version does recognise the need for patient and clinician choice and shared decision making. It does allow for flexibility to proceed with EVAR when it's felt to be the right course of action. And it does encourage closer scrutiny and surveillance of device performance over time. Now, that latter point is important because we now, through the National Vascular Registry, are starting to collect device information. So we will have a much better and clearer idea about the performance of individual stents and grafts. We hope that will also roll out to all items that we insert during a vascular procedure, but currently it's just our EVAR devices. Next slide. I have 3 slides just to finish off, which looks at our current NVR data, because the question is are the NICE guidelines going to change practice? Well, firstly, there has already been a small move towards offering more open surgical repair, which happened really before the NICE guidelines fully came out, and may have been because there was this discussion ongoing. So currently, or sort of from the NVR data for 2018, 37% of aortic aneurysm repairs were done as open procedures. Next slide, please. This is important to remember, that we do have a higher mortality rate for open procedures than we do for EVAR. And if we start moving some of those patients that are currently having EVAR procedures, we should expect that some of that higher mortality, that mortality will go up, because the reason that we've managed to push that mortality down is because we've been offering EVAR to our patients who we think have a slightly higher risk of mortality. Does mean that we will also be using more hospital beds, and because their average length of stay is longer. Next slide, please. One question that we have to ask is, could we do better? Could we prevent this problem with having a higher mortality for the open procedures? Well, I think that's challenging. As you can see, out of the NVR patients, 95% had a formal anaesthetic review, of which 91% were done by consultant anaesthetists. So on that basis, we're probably already getting an extremely good assessment of patients and whether they're fit for surgery. So I think at the end of the day, these NICE lines are a good, pragmatic approach to the problem, and do make us think about our practice and offer open surgical repair to individuals who are likely to do well, because in long term, they're probably going to get the best benefit of it. That's all I've got.
Thank you. Thank you. Sophie. Thank you very much. So that's a very comprehensive talk. Could I ask anybody if they have questions? If you want to use the chat function, Ronan. Are you on mute?
Sorry.
It's unlike me to be muted, but thank you. Thank you very much, Sophie, for an excellent presentation. How is this going to affect training? And now that vascular surgery has found itself to be a separate subspecialty of surgery with an emphasis on endovascular experience, do you think this is going to result in changes in how we train our vascular surgeons?
I think the important thing about this is that it recognises that there's still a role for open surgery in the younger patients. They're going to get a better long-term result. Now, in the UK, there's very much a push towards dual consultant operating. Now, clearly, we need to take our more senior trainees through these procedures and do it in a way that they are getting the exposure. But we need to protect ourselves and protect our backs, because you get scrutinized. I think that the move towards larger units, bringing together that expertise, possibly having fewer people who are actually undertaking the aortic procedures so that you get that specialization, is the right direction of travel. I think that the day of, surgeons, 1 or 2 surgeons in one hospital are gone, and that we're working in bigger units. I realise that it's more complicated in Ireland. You've got some interesting structures around how this hospital system works, and Kieran did try and explain that to us once, and I think I got lost after the first couple of slides. Your systems are complex, but in the UK, we are definitely moving towards larger centres, so that is good for the trainees. They get the wider experience, they get the full range of procedures, and they get that good supervision in surgical training.
Thank you. Any other questions for Sophie? Sophie, can I just ask you, the paper in the European Journal last month about the outcomes from the higher volume centres for open surgery. So it makes a difference. They felt volume and outcomes in open surgery, not as much in EVAR. In the UK, are you moving towards, we've long spoke about a number, you would have to do an expected number of procedures per year, and does that come into, it's been spoken about, is it being policed, I guess, in the UK?
Well, it is monitored through the NVR, definitely. And I think that there are 2 components about volume. There's the volume of the unit, which is just as important. So it's not just the individual surgeon, but it's about how you manage that patient right the way through. So actually having that good anaesthetic assessment, properly selecting your patients, having a good MDT that makes sure that your patients are as fit, optimizing them before surgery, and then appropriately managing them afterwards, having dedicated vascular anaesthetists that look after your patients, support your patients in the intensive care during their operative session, etc. All of that, it's a whole team. So yes, it's very important to have the right people doing the operation, but you're just a one cog in the wheel. So it's that whole team. And as I said, I think, dual operating does actually mean that you keep your numbers up. And, a lot of bigger units have dedicated aortic teams. And that's probably what we'll see. Currently, there are 70 vascular units in the UK, but probably within 10 years, it'll be down to 50, which is probably the right number for keeping up that volume.
Okay, thank you. Sharif, just one last question, and then we'll move on to our final speaker. Sharif, you have your hand raised there.
Thanks so much, Bridget. Sophie, this was fantastic. And you know how much I have debated about the NICE guidelines, and you're well aware of what's going on. I think that some of what I've said, I have to take it back, because currently now I'm seeing a surge of graft failures. I haven't seen it before. Micro leaks, hygromas, component separation in cases that was completely normal without any problem. And we have seen that even patients who coming in with TIA or had an MI and got a little bit of TPA, the aneurysm expands immediately. And I'm engaging with the CE in Europe and with the National Safety Authority of Ireland, and we're investigating this deeply. But I'll tell you one thing, we have a problem, and this is the tip of the iceberg. And I spoke with Nabil Shafi, and he had the same problem in France. So we have a problem bigger than expected. And I totally agree with the previous old NICE guideline. Open is the way forward, in spite of how much I'm in the vascular enthusiast.
Well,
Thanks, Sharif.
I think I agree with you. I think that, for the younger patient who's got a good long life expectancy, the open procedure is a good procedure. With EVAR, we have extended our range, and we offer surgery to people that in the past we wouldn't have even considered. So we need to have both tools, but we do need to be thinking really hard when we're offering an EVAR about the long-term effects. Yes, it gives them a short-term benefit, no question about it, but is that right long-term for them? So, you know, I think this has made us rethink, and I think it's right that we're rethinking.
Thanks so much.
Thanks, Sophie. Thanks, Sharif. So we'll move on now to our final speaker. So I'd like to introduce Mr. Douglas Orr, who's a vascular surgeon in Glasgow, and has probably spent the day in a darkened room recovering from the intercollegiate exams that took place over the last couple of days in Glasgow. And I think we were very fortunate that we were able to hold the exams remotely for several specialties in the college, and they went off very smoothly, really. So I think it's likely that the format is not going to change, at least in the very short term. So for those people who are sitting their exams, maybe at the next sitting or thereafter, may be interested in this, Doug is going to just give a very brief update. Thank you.
Thanks, Bridget, and thanks for your efforts over the last couple of days to help make it all happen. Okay, next slide, please. So when I'm asked to give talks about the exam, it's usually to trainees, and really all they want is told what questions are going to come up. They really just want somebody with a crystal ball who's going to tell them what questions will come up, and that's fine. But the shoe's been on the other foot slightly. I think it would have been interesting for those of us in JCIE if we'd had a crystal ball at the beginning of 2020. It might have alerted us to some of the challenges that were on the horizon for us. Next slide, please. So the traditional exam format for the vascular exam was a section 1 paper, which is the multiple choice questions, 2 papers, SBAs, EMIs, usually held in a driving test centre, and that's absolutely fine. It covers the whole curriculum, and that's been working well. The section 2 is the clinical exam. Next slide, please. And that's usually held over 2 days. And the first day is the clinical exam, and that's where we have patient contact. We see patients, we take a history, we examine them. And that's usually based in a local hospital. And Bridget was going to be the local organiser for the vascular exam in May of 2020. It was going to be held in Dublin. The second day is a day of oral examinations, and that's usually based in a nearby hotel. And there's a variety of different orals. Next slide, please. So in terms of the section 2 format, day 1, the clinical exam, each candidate will see 2 long cases. They're 20 minutes each, where they can take a long history, a proper examination, and then they'll be asked on the management of that patient. There will be 4 short cases, which are slightly more punchy, 10 minutes each. And that's over the first day. On the second day, as I said, there are oral examinations, and each candidate will have 2 case-based discussion orals covering 4 cases in total, 15 minutes for each case, 1 based on aneurysmal disease, 1 based on lower limb, 1 endovascular, and the last covering everything else we can't fit into the first 3 categories. They'll have a further 30-minute oral on emergency vascular surgery, and that will be 6 5-minute questions. And then a final 30-minute oral on elective vascular surgery, where there are 4 5-minute orals. And then there's a 10-minute academic foundation question, where candidates are asked to be aware of a published list of what are thought to be the important papers in vascular surgery. And they'll be asked questions around one of those papers, both from an academic and from a clinical perspective. Next slide, please. Who should be successful in the exam? Well, we're testing to the level of a day 1 consultant, and we want the candidates to demonstrate the knowledge that we think would be appropriate for clinical practice. So what does that mean in reality? Can this candidate supervise junior colleagues and run a clinic? Am I satisfied that this candidate could look after a member of my family? And I use the word satisfied. I don't say I'm delighted that this candidate is looking after a member of my family. We need to be satisfied. We want a candidate who is safe for day 1 consultant independent practice. Next slide, please. So that was all very well until COVID came along. Next slide, please. And that put everything up in the air. We were able to hold our first Section 1 exam in January of 2020, but by March and April, it was clear that COVID was in the march and there were major problems. We were in lockdown. There were joint surgical college statements and then decisions, and the decision was made that we could not run exams over summer or autumn, and hopefully we would be able to run exams in the latter part of 2020. It became clear that there would be lots of different bodies involved in all of this, between the General Medical Council, all the 4 surgical colleges, the trainee bodies. And it also became very clear that we needed to take government and public health along in all of this. It was realised, JCIE office is based in Edinburgh, and it was realised fairly early on that it was probably, if we were based in Edinburgh, it was probably easier to deal with Scottish government rather than Westminster government and so forth. And so fairly early on, it became clear that if we were going to run exams, we were probably going to run them somewhere in Scotland. Initially, the view was to use our NHS Louisa Jordan Hospital, which is the Scottish Nightingale Hospital, and we would have reduced patient numbers, but we would still try to have patient contact. That became clear that that wasn't going to be possible. We should only hold it in a hotel. There was concern that COVID was on the increase again by September, October, and the decision was made we cannot expose any patients to risk, and therefore we must have an exam which didn't have any patients. And so ultimately it was decided that we would run a specialty exam for all the surgical specialties over November and December in a venue in Scotland. Next slide, please. So over November and early December, all the 10 surgical specialties are running a diet of their exam. In vascular surgery, we had our May exam cancelled, and then our next exam would have been November, so we were still planning to run that. In other specialties, they've had up to 2 exams cancelled, so they have a significant number of candidates who have been held back until we've been able to deliver an exam. All these exams would have no patients. The long and the short cases would be replaced with clinical scenarios. The oral day would be normal. Face-to-face examination between examiners and candidates where possible, but recognising that some candidates would have travel restrictions or potential health issues, which meant they could not travel, and therefore their exam would be delivered remotely, and this would all be held in a hotel. Next slide, please. So as Bridget alluded to, I spent Monday and Tuesday in the Crown Plaza Hotel in Glasgow, where we delivered our vascular exam. We had 19 candidates, 13 examiners. That's slightly less examiners than we would normally have. We had 1 remote candidate sitting in the college in Dublin, being examined entirely remotely. In the venue where we had the exams, there were extensive safety measures in place. There were no patients, no examination. And as I said, the patient aspect was replaced by clinical scenarios focusing on history and examination. Next slide. And that, I suppose I'm biased, but I think we delivered a successful exam within the constraints of what were available. And that begs the question, where do we go with future exams? Our next exam should be in May of next year. And I think that will follow a very similar format to what we saw over Monday and Tuesday there. The plan would be that this will be held in Edinburgh, probably in the Royal College of Surgeons of Edinburgh as the venue. And I suppose we have to wait and see where we are with COVID and vaccines and so forth. But there may well be some element of remote delivery for that. But I think the hope is that we would still have face-to-face examinations. Further ahead, it raises the questions, what should we do? Should we go back to our previous normal? Or is this a time that we should be thinking of change? Should we have less patients? Should we have no patients? Should we take this away from a clinical venue, which is sometimes precarious in trying to get in, especially in NHS venues? Next slide, please. So the future exams, I think we will have our same section 1. We're moving away from EMI, so we'll have 2 SBA papers. The section 2, I think we will have orals as before. The clinicals, I think we'll probably aim to have less patients. We will try to maintain 2 long cases. We will replace short cases potentially with clinical scenarios. We've already agreed to change the academic papers. Some of the academic papers we've used are somewhat old and potentially out of date, and so these will be changed in the near future. And I think we will move to holding this in a hotel or a similar venue, and we will take this away from holding it in a clinical venue. Thank you very much.
Thanks, Douglas, for that. I think that was very helpful, and I know it was very stressful coming up to the exams, but everything did seem to run quite smoothly. Ronan, sorry, did you have your hand up?
Thank you, Douglas. Can I thank you on behalf of RCSI and our single candidate, but an extended thanks to all in JCIE who have pulled off a remarkable achievement with the trauma and orthopedics, general surgery and now vascular examinations having been successfully completed in these difficult times. And what a difference it is going to make to those who are trying to get their CCST and complete their training. So well done and many thanks. I think the issue is, will we ever go back to the way it was? And I think we won't. And I think you've alluded to that. And there is, I think once we can assure ourselves that the standards are the same, then that's sufficient. And of course, why do we need to just observe somebody examining a limb? If they've got to ST8 or ST7 levels and they've got through all of their annual assessments, then their workplace-based assessments, and with the new curriculum, I think then we don't need to rely on what was the old final med on steroids type examination. And I think it'll be interesting to see how it evolves. The question then will be for what happens with the international exams, but that's a different issue.
I agree with you completely. I think this is an opportunity for us to rethink. I agree with you again with the new curriculum coming in and the multiple consultant report. Things like examination and history taking should really be assessed in the workplace by the educational supervisors, etc., etc. And I don't think we really need to replicate that within the exam. And so I think it does give us an opportunity, not particularly driven by COVID, just with the new curriculum. It gives us an opportunity to look again at what we're trying to achieve with the exam and make sure we're examining the relevant bits that are ensuring these candidates are fit for independent practice. So yeah, I agree with you completely.
Thank you. Does anybody, any of the trainees have any, if they're online, have any queries about the exams before we finish up? For Douglas? I don't see any hands raised. Okay, well, thank you, Douglas. And can I
Bridget,
thank everybody again?
One question?
Yeah, Simon, sorry, yeah.
Sorry, I'm a rather senior person, but nevertheless, I would still regard myself as learning every day. So maybe I'm just the most senior trainee. But can I just ask Douglas perhaps a difficult question? And that is, if we don't have patients, do we really need to be face to face? And should we be thinking in the long term that maybe these exams could be completely delivered remotely, and that candidates could perhaps go to their local College of Surgeons or deanery, and as long as the internet holds up, be perfectly assessed as we're doing at the moment in certain cases?
Thanks, Simon. I'm not saying that we don't need to have patients. I'm not sure that we need to watch a trainee feel for a dorsalis pedis pulse. I think patients are at the core of what we do in vascular surgery. And as we've already heard from both Frank and Sophie's talk, actually talking to your patients and discussing things with them, treating your patient as an adult and taking their opinions is hugely important. So I'm not convinced that we can move away from patients entirely. I think communication with patients is a massively important part of what we do. And I think there is still something to be at least thought about in maintaining a communication side of things with real patients, where we're trying to explain things, we're trying to put over what the options are and discuss things with them. So I'm not entirely convinced that we can move away from patients in their entirety. I think we can lessen the number of patients that we can see, and I think we can utilize patients in the exam in a different way, rather than getting them to strip off and see if we can actually feel their foot pulses. But I think communication is integral in what we do, and finding a way that we can assess the candidates, ensure that they can communicate adequately with our clientele, I think is very important.
Thank you.
Okay, thanks Douglas again, and thanks to all three speakers. And I might just hand back to Professor O'Connell for the closing remarks.
Well, thank you, Bridget, and thank you to our vascular colleagues across the water for providing a very interesting and stimulating, and like Simon, I'm a little far on, but I certainly learned quite a bit this evening. And so I know where to go for my thoracic outlet problem, and I now know that I'm going to have an open aneurysm repair, and I know for sure I'm not going to do the intercollegiate examination. So thank you all so much, and I wish you good evening.
Nice.
Thank you, Bridget. Bye.